invite the next speaker, Dr. Ulhas. He will be delivering talk on the substrate-based ablation of ventricular arrhythmias. No, he will be talking on the integrated advanced multimodality imaging in VT abstract. Yes.
VT ablation, especially if it is a scar-mediated VT, can be very challenging. Acute and long-term success depend on how well you have defined the substrate, how accurately you identified those channels which you think are the cause for the sustenance or the genesis of the tachycardia. It's also important whether you would be able to actually visualize in real time the moment of the ablation catheter, whether it is accurately at that spot where you thought you identified the substrate, and whether the catheter is causing any damage. So if you are prepared with these kind of imaging, acute and short-term success rates are better. Maybe the safety is also increased, and what's more important, you would be also able to reduce significantly the fluoroscopy exposure. So there are a variety of imaging modalities to achieve this. For the structural details, your simple echocardiogram or TE, intraprocedural ICE, 3D electroanatomic mapping, and late gadolinium enhanced MRI, which we just now learned from Karthikeya, and CT scan images. When it comes to the viability of the scar tissue or the border zone, etc., the MRI scans, they do this double purpose. And recently another imaging modality, which is not yet being practiced in India but elsewhere, is to really identify the amount of innervation of the cardiac tissue by 1, 2, 3 MIBG nuclear scans. And if you really would like to see and accurately localize those channels, we now have significantly advanced diagnostic catheters with multiple electrodes which can record orthogonal electrograms and can detect those tiny channels. And the catheters are designed in such a way that we can visualize them in a real time, the force with which they contact the surface, and we are quite confident that we are not actually causing injury or perforation. So I think it is quite imperative, if you have taken the patient of VT, especially a scar or a structural heart disease associated VT, we should be having the information from as many imaging modalities as possible. I'm going to be talking now. The advances in the imaging technology has reached to a stage that now it appears to be very feasible to do entirely non-invasive VT ablation by stereotactic radiotherapy if you integrate multiple modalities of imaging, for example, MRI, PET-CT, and then advanced multi-electrode ECG, and then the CT scan. You can accurately identify and we can non-invasively do. So such is the advance with respect to imaging modalities in the VT ablation. I'm going to be speaking about few cases where I think imaging helped us. For example, a case here which looked like ARVD on the basis of the ECG, low voltages, atypical RBBB T-wave inversion, and further we thought it could be ARVD because of this very wide LBBB and the superior axis wide QRS tachycardia. Echo almost was diagnostic. However, utilizing the MRI helped us into not only to make more accurate diagnosis of this entity, but also identify the scar that is related, which typically in this case was there at the tricuspid trigone region of dyskinesia. So now imaging, when this patient was taken for the ablation, there is this feasibility of overlapping the anatomy, the scar anatomy. On top of that, now that we have these advanced catheters, you can overlap the late potentials or the fragmented potentials map on top of the conventional 3D electroanatomic mapping. So for example, typically you can notice that the trigone area of the tricuspid wall, a little bit extending into the RVOT, where with the purple colored map. Here you could actually localize such nice late potentials, and then that was considered to be the reason for that monomorphic VT. And because there was no inducibility, we did not go ahead for some epicardial or some other sites of ablation. So in this case, it was the MRI late potential map on top of conventional map, and the contact force visualization of the ablation catheter helped us. Good biventricular function, normal coronaries in an elderly man with syncopal episodes. The PVCs appear to be papillary muscle, atypical, RBBB, little wide on the leftward axis. He had syncopal episodes. Loop recorders showed several episodes of NSVT. Whenever a papillary muscle is suspected, ICE utility we have found to be extremely useful. We can identify that papillary muscle, and then you bring in a diagnostic catheter or an ablation catheter around that area, making use of that and then integrating with the 3D electroanatomic mapping. You can actually create the endocavitary map. So you are very certain that you are touching the papillary muscle, and then you make a separate map of that papillary muscle, which was not possible before this kind of imaging tool has come. And what you notice here is an ablation catheter. The green tipped catheter is an ablation catheter. And then you have several things on the screen where you will know the contact, the force that is generated. And on the right hand side of the screen, you would be able to appreciate, I believe, that the early onset of the local electrogram with respect to the PVC, the QS pattern. Looking at this particular skin, how comfortable you are. And then you are not stepping onto the fluoroscopy, that's also very important. So this endocavitary depiction of the structure, and then looking at the real-time catheter contact helps. So as expected, this case was a very quick case, and then it was successful. Papillary muscle, we invade whenever that is suspected. Papillary muscle VT, we use ICE. But in general, over a period of time, ICE has become an integral part of our ablation procedure whenever we deal with VT or atrial fibrillation. This is a VT storm in a young man, refractory to medications. Normal heart. So somehow we managed to get him onto this. So the imaging helped here. PET CT scan, Bhargava told so very neatly. And then we could do the CT guided biopsy. It turned out to be sarcoid. MRI delineated the scar to be typically located epicardially, in addition to, of course, a septal scar. In addition to in and around the septal zone, we needed to be doing a little more job because the MRI suggested this epicardial and the subepicardial zone. So without those PET CT scan and the MRI scan, and then the integration, we must not have been able to do the case. So this is the epicardial signals. So I would be talking at the end another case here, and this is the integration of CT scan images for a papillary muscle VT. For example, on the left hand side is the CT scan. On the right hand side, you have focused mode on the papillary muscles. On the right, the yellow is the anterolateral, and the and the purple is the posteropapillary muscle. Again, bring in the catheter near the papillary muscle with the use of the eyes and make focused map of those papillary muscles. On the right hand side, you see the HD grid map showing so neatly the electrograms, and then in the lower part of that is the QS complexes. What was considered to be a difficult case, this case was the third time I was undergoing the procedure. The imaging helped, and then it was in a real quick time we could do the case. Similarly, the moderator band, again integration. So at our place, the imaging protocols, especially scar-related VTs, are going to be LGE, CMRI, PET-CT, ICE, and the integration of all these images. Recently, our radiologists are interested in looking at the MRI-derived scar information on top of the CT plus the electro-anatomic mapping. So without integration of those imaging modalities, it is very difficult, and if you pursue on this technology, acute and short-term success rates are high, safety is high, you reduce fluoroscopy, and there's a healthy environment around. Thank you.
Thank you, Ulhas, for a wonderful presentation. Any questions or comments from the audience, please?
Overlapping of coronary imaging, particularly if you are ablating epicardial, you need coronary imaging.
Yes.
So every time you can overlap coronary image, CT coronary image over the electroanatomical map.
Surely, and of course, coronary angiogram is also an important imaging modality, especially when you are doing the epicardial ablation. So maybe you'll have to take shots during that time, not necessarily, depending on the CT scan images, but the real-time coronary angiogram is so very important when you do the epicardial ablations. Maybe even even sometimes inside the heart, whether you are nearer to the coronaries or no.